Alright everyone, welcome back. I bet you've always been wondering where bilirubin comes from. Like long sleepless nights trying to figure out how the heck did this bilirubin get in the body in the first place. Well, we're going to find out now. It all comes, guess where? From heme. So we have a common pathway of a fetus versus a neonate. So the reason why the fetus and neonate have different bilirubin metabolisms is because the fetus doesn't have bowel movements, but the neonate does. So it creates a different kind of pathway necessary to get rid of bilirubin. So let's start with the common pathway that's common to both the fetus and the neonate. We have our heme, the red blood cells. This is the origin of all of the bilirubin in our body. And when we have old red blood cells, or we want to turn over red blood cells, the thing that does that for us is the reticuloendothelial system, the liver and the spleen. They take out old red blood cells from the body and replace it with unconjugated bilirubin. So here's our friend here. So this is what's going to cause all the problems in this neonate. But the crazy thing is that we're creating it ourselves. So we need to find a way to get rid of it just as we are creating it. And that's what we're going to find out. It's carried by albumin in the blood to the liver. We talked about this previously, the importance of albumin. So unconjugated bilirubin is very fat soluble. It can't dissolve into the plasma, so it needs to be carried by albumin. And when it reaches the liver, it gets conjugated by the UDP glucuronidyltransferase enzyme. And then we have our safe form, conjugated bilirubin, that doesn't cause us problems. But now we have a problem. What are we going to do with this conjugated bilirubin? And this is where we get to the two pathways where they start to split. So in both the fetal and the neonatal pathway, the conjugated bilirubin is secreted into the GI tract by the bile. So that's why the bile is yellow colored and greenish colored, because of the bilirubin that's found inside of it. And since this conjugated bilirubin cannot be excreted, like we mentioned, the fetus doesn't have bowel movements, what are we going to do? We can't do anything with it except for recycle it. So beta-glucuronidase is released from the infant's or the fetus's small intestinal brush border, and we get unconjugated bilirubin again. So hence here's the problem. We have now remade the unconjugated bilirubin that we didn't want, and now it's going back into fetal circulation. But the nice thing is that because the fetus is inside of the mother and has a connection to the maternal blood through the placenta, as the unconjugated bilirubin builds up, it goes and transfers across the placenta, and guess what? Mom takes care of it, conjugates and excretes it out of the system. But just like when we grow up, we have to stop depending on our parents. Once again, the neonate can't depend on the mom forever. So now we have the neonatal pathway. So in the neonatal pathway, it's secreted by the GI tract, via the bile into the GI tract. But the problem is that we can't do much with it when we're really, really young neonates. We don't have enough GI bacteria to oxidize the conjugated bilirubin into excretable forms, such as urobilinogen, urobilin, and stercobilin. So we get an excess of conjugated bilirubin in the GI tract. So we have a problem. We don't have enough bacteria, which is kind of strange because we're always worried about bacteria. In this situation, we want more. So we have two different things that we can do because we don't have enough GI bacteria and excess conjugated bilirubin. So as you mentioned before, the bacteria oxidize conjugated bilirubin into urobilinogen, but this can't really be done. There's not enough bacteria. So there's two pathways for conjugated bilirubin to go. The first is just like before in the fetal pathway, it gets broken down by beta-glucuronidase back into unconjugated bilirubin, and that's reabsorbed into the circulation, and that's called enterohepatic cycling. It goes from the intestine back to the liver through the portal circulation, so you never lost the unconjugated bilirubin. And this is one of the reasons you get physiologic jaundice in neonates, because you can't get rid of the unconjugated bilirubin until the GI bacteria get up into a sufficient quantity. But there is one way to get rid of this excess conjugated bilirubin, and that's through feeding. So if you have a gastrocolic reflex feeding, you're going to have more conjugated bilirubin lost in the stool, because when the breast milk enters the stomach, the colon starts having peristalsis, and you lose some conjugated bilirubin. But this isn't a majority. System. What you'd rather have is a GI bacteria converting the conjugated bilirubin to urobilinogen, so it can convert to urobilin, which makes the urine yellow, and stercobilin, which makes the stool brown. Okay, let's move on. Causes of hyperbilirubinemia. So I have to warn you, there are a lot of causes, but we'll go through each one in slow detail and break it down so you'll understand all of these. But important things to know is that you have to understand why some of these diseases are mixed conjugated and unconjugated. So mixed means having a lot of conjugated and unconjugated bilirubin. Conjugated means having greater than 20% of total being conjugated, and unconjugated is when unconjugated predominates. Okay? So remember, conjugated hyperbilirubinemia, it just needs to be more than 20% of the total bilirubin. So that's something to keep in mind. So, first cause, decreased liver uptake of unconjugated bilirubin. Makes sense, right? If you can't take up unconjugated bilirubin, how are you going to get rid of it? You're not. So, hepatitis and cirrhosis, neonatal hepatitis, commonly from transmission from the mother to the child by hepatitis B, that can cause the liver not to take it up. And cirrhosis as well, if you have some kind of genetic defect that damages the liver, you can't conjugate the bilirubin, so you get an unconjugated hyperbilirubinemia. One of the many different causes. Next is increased production by the reticular endothelial system. So remember, all the heme that's being broken down is getting converted to unconjugated bilirubin by the RES. But what if we have problems that have way too much being produced, such as too much blood breakdown or too much blood being there in the first place? We have a problem. And that's why it's all unconjugated, because the RES is going to keep on making unconjugated bilirubin, but the liver in this neonate can't handle these large quantities, so it all builds up. So hyperviscosity, what does that mean? Too much viscosity, too much blood. Blood is the most viscous part of our solution in our vasculature. So we have too much blood, polycythemia, either due to some excessive red blood cells from a genetic defect or from maternal fetal transfusion and delayed umbilical cord clamping. So if you don't clamp the umbilical cord in time, a lot of maternal blood can end up in the fetal circulation and overwhelm the fetus and have congestion and hyperviscosity. And what's the body going to do to compensate? Break it all down. And guess what you make? Yeah, unconjugated bilirubin, and that can cause some severe issues. Next, extravascular hemolysis. So that means that we are destroying red blood cells, just destroying them, nuking them out in the extravascular space. And this is spherocytosis or hematoma breakdown. So when you have hematoma breakdown or spherocytosis, you're destroying blood cells outside of the vasculature. In spherocytosis, the spleen does it, and hematoma breakdown is happening in a collection of blood, such as a cephalohematoma. All of that blood, what's the heme going to be converted to? Once again, unconjugated bilirubin. You sense a theme here? And last thing, intravascular hemolysis means that the red blood cells are destroyed inside the vasculature. So there's some problem with the red blood cells, cause them to just fall apart. And there's G6PD, Rh incompatibility, thalassemia, sickle cell. All of these things can cause damage and destruction of the red blood cells, and heme is released, and heme gets converted to unconjugated bilirubin. So that's why they'll all be unconjugated. Next is decreased conjugation itself. So that's pretty self-explanatory. If you can't conjugate, you're not going to have conjugated bilirubin. You're going to have an excess of unconjugated bilirubin, and you have jaundice and a problem. You look like the Simpsons. So, Crigler-Najjar type 1 and 2. We talked about Crigler-Najjar a little bit in the introductory question that we started off with. And remember that that's a complete deficiency of the UDP glucuronidyltransferase. And type 2 is a little bit less of it. It's not as severe as type 1 because there's some activity of the enzyme left, but it still can cause a unconjugated hyperbilirubinemia. Gilbert syndrome, this is the great debate of how to pronounce it, like the French or like the Americans. You're going to have decreased activity of the UDP glucuronidyltransferase with stress. So you have some kind of stressful situation, such as an infection or a really hard test coming up, but an infant's probably not going to take a test. If you have starvation, anything like that can trigger Gilbert syndrome and cause the buildup of unconjugated bilirubin because the enzyme UDP glucuronidyltransferase will stop working. Next, prematurity. The more premature the baby is, we talked about before, the less mature the UDP enzyme is, and you're going to have less conjugation. And hypothyroidism, when you have hypothyroidism, all the enzymes in your body have a decreased reaction rate, so you won't have as good conjugation. Next is decreased bile flow. So if you have decreased bile flow, remember the bile, as we noticed in the last slide with the pathway, it's found after the conjugation step. So if the bile is damaged and the bile flow is affected, you'll have an excess of conjugated bilirubin because it's all been conjugated already. Okay? So not as much of a risk for kernicterus as we have before. So the examples here are cholestasis, which means slowing of the bile, because that's going to back up the bile and cause conjugated bilirubin. TPN, because you're going to have only food being given by the IV line instead of orally through the GI tract. If you don't have the GI tract getting food, you don't have CCK, and you don't have contraction of the gallbladder and the bile ducts, and bile backs up. Sepsis. Key thing you want to know about sepsis that's super USMLE relevant is if you have a baby being born with a fever and jaundice, or has jaundice very early on in life, you need to be very worried about sepsis being the cause here. Okay? And that can cause conjugated and mixed hyperbilirubinemia. Conjugated because it damages the liver and the portal and the ducts, the bile ducts themselves. Not the portal system, it damages the bile ducts themselves. And next is cystic fibrosis biliary atresia. They damage the bile ducts. We've talked about this, what happens if you damage the bile ducts. And Dubin-Johnson and Roeder we're going to talk about in detail a little bit later. But these are inherited defects that prevent you from transporting the conjugated bilirubin into the bile ducts themselves. And we'll talk about that later. Finally, we have increased enterohepatic circulation. So all of these will be unconjugated, and we'll find out why. We talked about in the previous slides that enterohepatic circulation means that the beta-glucuronidase enzyme converts the conjugated bilirubin back to unconjugated bilirubin and recycles it. So we have an excess of what? Unconjugated bilirubin. So examples of these are ileus, because you have a long delayed time in the GI tract, so you have more chances for the beta-glucuronidase to encounter the conjugated bilirubin. Breast milk jaundice, which we'll talk about in the next slide, and breastfeeding jaundice also, which we'll talk about in the next slide. Both of these cause excess unconjugated bilirubin in the GI tract and increased circulation back into the systemic circulation. So causes of ileus that I want to just quickly talk to you about. Opiates can cause slowing down the GI tract, low potassium levels, and also high magnesium levels. Key things to know for step 2. Now we'll talk about benign versus pathologic jaundice. So today, for now, in this presentation, we're going to talk about happy jaundice, good jaundice, okay? So benign jaundice criteria. The jaundice appears after 24 hours of life and lasts less than 2 weeks. So remember, we talked about sepsis presenting within the first 24 hours. A pretty good indicator of benign jaundice is if it shows up after 24 hours of life. Think of that smiley face. He's good for 1 day. And it lasts less than 2 weeks. The longer it lasts, the more likely there are going to be problems, and the higher the chance of kernicter is. So we want it to last as short as possible in less than 2 weeks to prevent deposition. No serious symptoms. Remember, we talked about how important symptoms are. Sometimes symptoms are even more important than labs. So if you don't have symptoms, that means it's good. You don't have any neurologic signs like seizures, hypertonia. You don't have any cerebral palsy. You don't have any lethargy, poor feeding. If the baby is fine, that's a good sign, and it's probably benign jaundice. And also, we want to know the total serum bilirubin is less than 18. So I know not memorizing isn't fun, but this is one of those numbers you have to memorize. If the bilirubin is less than 18 and the patient is a term infant, most likely it's not a very severe jaundice. So this smiley face, is it actually jaundiced, or why is it yellow? I always wondered that. On all of our texts and all of our apps, we always have yellow smiley faces. We've been encountering jaundice all the time. Examples of benign jaundice. We have physiologic jaundice. Okay? Physiologic jaundice is the one that we always hear about. And most infants will actually have this kind of jaundice. And the reason why is that we have a lot of mechanisms going on when we're born that lead to heme breakdown and excess unconjugated bilirubin. So the thing you want to remember is it presents after 24 hours of life and resolves in a week. Remember, that's the opposite of what's going on here. Okay? And it's caused by decreased neonatal red blood cell lifespan. Remember, when we are in utero, we have hemoglobin F because of the high affinity for oxygen. All that hemoglobin F needs to be destroyed. And what happens when you destroy hemoglobin? You make unconjugated bilirubin. So that's why you have tons of neonatal breakdown from red blood cells. Next, the UDP gluconeotransferase enzyme is immature. It can't handle the bilirubin load yet. So it's going to build up the unconjugated bilirubin. You also have decreased intestinal bacteria. We talked about that. So you can have excess unconjugated bilirubin. And you'll have increased enterohepatic cycling because of the beta-glucuronidase found in the brush border. And like we said before, total bilirubin levels are less than 18. Very important, and will fall by the first week. Alright, now let's talk about breastfeeding failure jaundice. So this occurs in the first week of life, after 24 hours. Just like we said, if you have jaundice after 24 hours, that's our happy jaundice, our smiley face here. And it also occurs in the first week of life and resolves usually within the first week of life with treatment. So causes of this is a problem with breastfeeding. It's a failure of breastfeeding. So there are many ways to have breastfeeding failure. One is poor latching, where the baby is not used to breastfeeding and doesn't do it properly. Decreased breast milk production, some kind of issue with the production of the milk, either by hormone imbalances, and dehydration as well. Okay? So dehydration of the infant leads to this breastfeeding failure jaundice, and we'll talk about how that gets involved in this next bullet point here. So what happens? It results in rapid weight loss, secondary to malnutrition and dehydration. So when you lose weight and you're also dehydrated, your concentration goes way up. And what's going to go up also if you lose water? The concentration of bilirubin. And that's going to be reabsorbed in the enterohepatic cycling. You also have increased enterohepatic cycling, like I just mentioned. You have increased water absorption in the GI tract to compensate for dehydration. That concentrates the bilirubin, and guess what happens? Gets reabsorbed, and you never get rid of it. And when it gets high enough, you get kernicterus. So major problem here we need to watch out for. And also, usually we don't like bacteria. We want to treat them. We want to wash our hands. But guess what? As babies, we need our little friends here. So there's not enough bacteria in the GI tract. You can't convert the unconjugated and conjugated bilirubin to urobilinogen. So what happens? The conjugated bilirubin converts to unconjugated bilirubin and gets reabsorbed. So one of the few times we want some bacteria hanging out to help us out. Now let's talk about breast milk jaundice. So this is a little bit different. Breastfeeding failure jaundice is a problem with breastfeeding causing dehydration of the infant, while breast milk jaundice means that the breast milk itself is causing the problem. So it starts at the end of the first week of life. The way to tell the difference is breastfeeding failure jaundice happens around day 3 to 5. Breast milk jaundice happens around day 7, end of the first week, and it extends into the second week of life. You see the jaundice and bilirubinemia are greatest in the second week. That's the biggest way to differentiate breast milk from breastfeeding. Everyone always gets these confused, so now you know the secret. So the cause, excess beta-glucuronidase in the breast milk triggers increased enterohepatic cycling because beta-glucuronidase converts conjugated to unconjugated bilirubin, and the unconjugated bilirubin gets reabsorbed and cannot be excreted from the body. So now, just like last time, I want you to go through all the stuff you've learned in your mind and write down everything that you remember. And this will completely improve the amount of knowledge you retain, and will also help you with understanding and compartmentalizing what you learned as well. So go ahead and do that, and we'll start the next presentation.